I'm gonna go ahead and record our class. It's where it shows video and stuff. That way I can put it in the Jones apartment side. All right, let me go back over here real quick.
Hi, everybody. Welcome to the BCEHS course on Igel tips, tricks, and troubleshooting. Over the next several minutes,
All right, everybody
we'll
listen.
through some of the most common questions, pitfalls, and solutions when using the Igel for airway management. When Igels were first introduced in paramedic practice here in BCEHS, our initial training focused heavily on insertion technique, sizing, and function when things were working well. But there was very little knowledge institutionally among paramedics about how to respond when the Igel didn't work as expected, or how to troubleshoot various issues as they came up. And that's what this video is going to focus on. The first difference that most people noticed when the Igels actually showed up on car was they came in something called a resus pack, which is different from the stripped Igel with a separate Thomas tube holder that we were all trained on. The resus pack comes with a neoprene elastic head strap, water-based lubricant, and a gastric tube for suction into the gastric channel if needed. Prepping for insertion of the Igel is very similar with the resus pack. We still want to lay out our strapping behind the patient's head, just beneath the occiput, so it's not a risk for slipping or brushing the jugular veins, and we're not fumbling with it once we've got the Igel inserted and we're trying to maintain a good seal. One of the tips that's come out after multiple uses of the Igel and some difficulty with insertion is the importance of lubricating the spine more than anything else on the Igel. Obviously, it's still important to lubricate the tips and the sides and wherever possible, the front without leaving a bolus of lubricant in the cup. But the spine itself is what actually comes in contact with the majority of the tissue on insertion, as you see here. Another common pitfall is forgetting to pre-suction the patient before insertion. Any gastric secretions or saliva present in the back of the throat before insertion are going to cause issues with Igel seating afterwards. Head position has been shown to be really important when it comes to proper function of the Igel. Too much flexion or too much extension will cause failure of the Igel to seat. Sniffing position is a preferred position for insertion, but it's really important to remember to bring the head up into neutral before placing it in sniffing, and that might require padding under the head in some of those cases. A big change of practice right now with the current pandemic that we'd like all paramedics to be aware of is the need to place the bacterial viral filter on the end of the Igel before inserting it into the patient. If there's any coughing, gagging, inadvertent CPR compressions after insertion without the filter, and aerosolized material directly at the provider, and that's really unsafe. Securing the Igel with the included head strap is quite simple. There are hooks on the end of the Igel and corresponding loops on either side of the elastic strap. The hard part is just to make sure that you maintain a downward pressure or posterior pressure the entire time while you're securing, because any slack can allow the Igel to back off and fail to seat properly. It's important to confirm proper Igel placement both immediately after insertion and on an ongoing basis throughout the call. This is done by watching for chest rise, auscultating over the epigastrum, auscultating the upper lung fields, and by watching for changes in the oxygen saturation. It's also important to continuously monitor the compliance of the bag during ventilation. Regardless of the device you use to secure the Igel, it's important that posterior pressure be maintained at all times, or else a risk of losing the seal will occur. The Thomas tube holder is a controversial device when it comes to securing the Igel. It can work, but it's a little bit more difficult to be done right. The mouthpiece has to be placed securely in the mouth with a bite block between the teeth. The head straps need to be secured snugly not including the jugular veins, before attempting to secure the Igel. It's also quite important that with a little bit of lubricant, the Igel can easily back off. So downward pressure has to be applied and then maintained. Good old-fashioned transport tape can actually be quite effective in securing the airway, as it has a bit of elasticity built into it. The trick is to place it quite high up on the Igel itself, so you can get a bit of a downward angle to stretch and apply some posterior pressure and then maintain it. There's a separate video on the DCHS YouTube channel that covers all the indications and step-by-step procedures for suctioning through the gastric channel on the Igel. So if you haven't watched that yet, I'd highly recommend you go and give it a look. One of the key points I will remind people of is the need for adequate lubrication over the opening to the gastric channel. Without sufficient lubrication, people are finding it very difficult to pass the G-tube. If you have difficulty passing the G-tube, or if it becomes stuck partway down, try backing it out, adding a bit more lubricant over the opening, and try reinserting from there. Troubleshooting Igel difficulties is to follow a step-by-step approach. Assess the head position to make sure it's not hyperflexed or hyperextended. Look to make sure the Igel hasn't backed out or hasn't gone in too deep. And make sure that no fluid has passed into the oropharynx or into the gastric tube. If you're pulling a lot of fluid out from the oropharynx with suctioning, that means that the fluid has likely bypassed the Igel cuff, and the Igel needs to be removed so that the airway can be thoroughly decontaminated. Before removing the Igel, the G-tube needs to be removed very carefully and placed into a sealed bag where it can't contaminate anyone. And then the Igel needs to be very slowly removed with ongoing oral pharyngeal suction to both limit the splash and to keep any contaminants from soiling the airway of the patient. Once the Igel is out, it needs to go into a package. If it's going to be reinserted, it can be kept handy, otherwise it can be disposed of. The airway should likely be thoroughly decontaminated. And then you're going to move to a 2-person BDM with a filter in place and a very good seal. Igels are a relatively new tool to paramedics in BC, and we're still learning how best to use them and incorporate them into our practice. If you have any questions or suggestions on how best to improve.
Okay, so the only thing is on this is that if you take it out, we're going to clean it, reuse it again. We're not going to throw that thing away. It's pretty expensive. Oh, I like that.
I'll put it in.
Okay. Oh, don't put it in me. I don't care.
Yeah, but also then you on the same page.
I guess that's for aspirations.
All right.
How do you like
I was going to hand out the sheets for, I'm going to pass around sheets for supraglottic airway. Now, and I'm going to pass around the sheet for the CPAP. So on the CPAP, down here, it's going to say like titrate oxygen concentration, sets tidal volume. We don't have these CPAPs don't have that, right? These CPAPs.
I'm sorry, that's right there.
CPAP.
I think you can see that also. Yeah, these are set up, but you are going to there was one super body. I think it might be.
I may have made copies of that twice. I'll get the one for supraglottic. We're getting CPAP coming around there. Yep. All right, so anyway, back to CPAP here. It'll say like, all that, our CPAP, we'll go over it, but it's really simple. There's old school CPAPs in here, but still the basic principle that take it out of the package, you plug it up, and put about 12 liters per minute. And this one actually, this one you can adjust it a little bit, but we want the max, somewhere around the max heat of 13, so it would be like 15 liters per minute. All right, but that's where you want to start. You know, just crank her up to 15, and once you've got your O2 set, it's just all about applying the mask. Right, this is go ahead and set here. And what you would do is have the patient hold this to their face, put a roll onto it, wrap it around their head, and then Velcro it in. Not bad. Okay, because that's pretty much the CPAP. But on there, it has, you know, how do we, what are we going to consider CPAP for? And what's it contraindicated? What can we not use it for?
What?
Right. So if you look out, so the big one here, if you're looking at, so let's say, so most of the time you're going to be using CPAP for a patient with pulmonary edema. All right. What's some signs and symptoms of pulmonary edema? Crackles, rails. What else?
Can't breathe when they're laying down.
What's that?
Can't breathe when they're laying
So
down.
orthopnea. Possibly, yeah. Go with that. What else? What's some more physical signs? Okay, edema. After y'all are guessing, this you should be confident. Edema. Where at? In the feet. Bilateral lower extremity, pedal edema, right? What else? There's one more I haven't heard yet that I know of. Pulmonary edema. Chest or heart failure. So, all right. So let's general assessment of your patient. General appearance. You walk in. How do you, right? This patient's either going to be tripod sitting or tripod standing, right? Moderate to severe distress, right? Okay, so now let's distinguish the difference. We got to figure out why. Is this an asthma patient? Is this a heart failure patient? COPD? So let's work through this. And so we said edema, okay? And majority of the time you'll see edema, sometimes you won't. We said rails, that's a good one, right? We can hear fluid, right? All right, give me one more physical sign. Okay, it could be diaphoretic, JVD, jugular vein distension. All right, so we all know in the pre-hospital setting that JVD is not always apparent, and neither is lower extremity edema always apparent, depending on if you're dealing with a person who's obese. It's hard to tell sometimes. Are they really swollen or not? Right? Is it always easy to hear lung sounds in an uncontrolled environment? No, it's not. So what's something else in that's objective, right, that you could look at to determine blood pressure? What would we suspect this patient would be? Hypertensive, majorly usually. 190, 110, 200 over 120, right? Because, why, Suda? Why they're hypertensive? Why? Using your own analogy.
Oh, the too high of a preload, so your heart is gonna start to get worse.
And it's hard to what? It's hard to walk against the what? Yeah, it's hard to walk in the Lazy River with the currents coming towards you, right? So that's why. And so, okay, so for years, I practiced as a paramedic, we didn't have CPAP. Didn't have it. Had to figure out a way to provide care to a patient that was pretty much knocking on death's door from this. And so, but what do we need to do to fix this at your level? How are we gonna fix it? Okay, CPAP. And so what does CPAP do? Go force area, okay. And so forcing area does what? What's it do to the lungs? Expands them, right? It's going to expand the lungs. And what do we have down here? I'm sorry, in part of the lungs. I'm talking about the lungs. We have the lungs itself, and we have alveoli. Where is this fluid at? It's at the bottom, and it's surrounding the what? The alveoli. And then just below the alveoli, there's a part of the lung that we discussed a little bit in physiology, not probably didn't. Probably just spent a lot of time. It's two words. Dead space. Dead space. Right? And does anybody remember the size of the dead space? Yeah, size would be in milliliters. Get close? Nope. So about 200 milliliters of dead space. And that 200 milliliters of dead space, we oxygenate occasionally when we have that sigh. You may not even know you're doing it when you do it, but your body has a time and mechanism in place where it goes, okay, I need that oxygenated. So you'll breathe a little deeper than you normally do. And so that's how it's taken. Well, what we want to do is we want to displace that fluid. We want to move the fluid away from the alveoli, and we want to move it into that dead space, right? And so you'll see a lot of times, a lot of emphysema patients, because we know their alveoli are toast, right? What they'll do is something to keep their lungs expanded for a little longer. Does anybody know what that is?
Pursed lips.
The grunt, pursed lips, right? Right. So you'll see them every now and then, like they're whistling. And what they're doing is called PEEP. Yep. And it's positive what? PEEP. Yep. Positive end expiratory pressure. And that's what CPAP does for you. That's what CPAP does for you. It's going to increase the PEEP and allow those lungs to stay inflated longer, which inflates your dead space, which lets that fluid go down. How quick do you think it works? Pretty quick. A lot of times it works really quick. The only thing you find occasionally is the patient who's panicked because they're drowning, right? And sometimes when you're drowning, it takes a minute or two for you to figure out that what this other person's doing for you is helping you. Their body's in survival mode. So imagine somebody's trying to put something over your face. Your body, even though it makes sense, it's oxygen. It's going to help you. Your body doesn't look at it that way. Your body's like, don't put anything in my face right now. I got to breathe. I got to breathe. I got to breathe. That's all that's going on in your brain, right? It's this drive to breathe. And it kind of goes back to the body's way of survival when it comes to keeping everything in check, right? Your body's going to work to keep the heart rate at between 80 and 100 because it knows that's fine for it. I was gonna keep your respiratory rate between what, 12 and 20, because that's where it's best at. You don't know that. I mean, you don't consciously think of that, right? You're not always thinking, I need to keep my respiratory rate between 12 and 20. No, you're not. But your brain is, whether you think about it or not, there's a section in your brain that does that. So when things start getting out of whack, it starts taking over. It starts taking over. It's like, no, we're gonna die. So it's kind of like it sits back there, it's command and control, and it doesn't take command very often, but when it does, it does. So nope, I'm in command. You're gonna do what I say do, even though it's irrational. And so anyway, so fighting through with the patient for a little while for them to figure out, oh, what you're doing is working. And once they figure that out, it's done. They go back to the state of being compliant. They're a lot more calm, and you can manage them. These patients, seriously, these patients I've had to medicate before because I can't get them to sit down on the stretcher. They will not sit down. So how are we going to get them out of the house if we can't get them on a stair chair, right? Because they won't sit down, so you have to medicate them. You may be able to CPAP them, and they'll figure it out in a few minutes, and they'll sit down. I've had situations where I will roll it up on the scene, and the fire department guys were walking this patient out, which is the worst thing you could do. But they couldn't get him to sit down in the stair chair, and so they resolved it by doing that. They didn't do anything else to do. You have to educate. Say, hey, no, next time just leave them there. I'll come in and medicate them. Right? I'll hammer them with some morphine, and make them dizzy, and they'll sit down. All right. So, but that's CPAP, and so let's look at it. Let's look at what we can't use it for, because that's important. All right, and so the sheet here says, okay, let's assess the patient to identify the indication for CPAP. Are we dealing with congestive heart failure, pulmonary edema, asthma, pneumonia, COPD? The preferred thing we want to use this for is pulmonary edema. Some places are using it for asthma. Okay, some places are using it for COPD. You got to be cautious, though. You got to be cautious because the problem with asthma is not a displacement of fluids. It's constriction. Maybe we can open the lungs up with the peak and it might oxygenate, but the problem is getting air out a lot of times. So we might end up causing a pneumo. And we might end up causing a pneumo with somebody with COPD. Why do you think that is? I have emphysema, COPD, and you come along with a CPAP, it's too much pressure. Their lungs are what? Their lungs are weak. Their lungs are weak for whatever reason, smoking or industry work that they, had a bad environment. They inhaled toxins for several years. So their lungs are weak. So we really don't want you to use it for COPD. I want you to use drugs for COPD, not this. All right, so let's look. Okay, the very first thing says for when we're looking at contraindications, an unconscious, unresponsive person, inability to protect their airway, inability to speak. Why then would we not want to use CPAP for this? Right. So I see this in the hospital. Ours is called BiPAP, but it's the same general principle. And I'll see it where a patient is getting tired. And remember, we talked about that in EMT school. Because the patient will start saying, I'm tired. I'm tired. So they can't speak with like one word sentences. And then they start the head boss things. All right. Then your patient is fixing to be respiratory failure. I mean, they're there. Basically, if they're head bopping, they're there. All right, so, but with BiPAP or CPAP, if you actually held that patient's head, realistically, probably could keep, it probably, wouldn't be a problem. But you're not gonna do that. Because why? Because you got 150 other things to do besides dedicate yourself to holding that head like that. And you're gonna be under a false impression that the CPAP's gonna work when their head goes like this. It's not. Right, then you got the tongue to worry about. It's not, so there's too many dangers in that. And I don't know, it had been long ago, probably not last weekend, a couple weekends before that. I was talking to one of our physicians over there, and I was like, hey, doc, yeah, they're in failure. Probably need a tube there. And he's like, yeah, we do. I'll fix it too. Let me go get stuff. Right? Came back in, a few minutes later. The patient was still sat and great, good chest rise and fall, because her head was in a good position, and we tubed that patient. Because that lost the inability, she lost her inability to speak, she lost her inability to protect her airway. We have to always protect the airway at all costs. And so that's the number one thing. So an inability to sit up. If the patient can't maintain a certain posture, like I was just saying, then they can't maintain their airway. Again, respiratory arrest or agonal respirations is failure, right? I gave you a scenario where I said patients breathing 2 times a minute with deep sighing respirations. That's agonal. All right, nausea and vomiting. It's kind of common sense saying patients got this mask on. If they start vomiting inside that mask, what are they going to do? Aspirate, right. All right, I suspected pneumothorax, obviously. Cardiogenic shock. Okay, cardiogenic shock. So, and we had one kind of with your squad back there. Remember yesterday, asthma, everybody kind of leaned toward asthma, right? But ended up being an MI, right? And so a lot of times what happens is when you have a big MI, you lose that contractility of the heart. And if the heart can't contract efficiently, what happens to the blood? Backing up, right? Backing up goes into, backing up into the pulmonary artery, starts leaking at the capillaries, right? And so then we start getting edema. And sometimes when you listen to those lung sounds, you can have a high-pitched wheeze, and it can be mistaken for asthma. Matter of fact, it's got its own name in the medical community. We call it cardiac asthma because it sounds like asthma.
With the result of cardiogenic shock, pulmonary edema, though?
It would be.
It's not indicated for a CPAP.
It is, but hold on. So what ends up happening with this is that once you lose contractility of the heart, all that, if we put CPAP on, somebody having an active MI, it starts messing around with intrathoracic pressure. And we're already probably going to end up having a low blood pressure anyway, and we're fixing to make it worse. So hypotension would be another contraindication. But
The scenario was yesterday where there was wheezing sounds. It was a cardio.
that's what I'm talking about.
So when you're pushing air into the lungs, is it sort of like obstructive job kind of because it's pushing up against the
They
heart?
can.
Make it preload.
Absolutely right. It can become like an obstructive type. I don't want to say call it obstructive, but it's enough to where, like if I'm 210 over 180, or sorry, 210 over 120, that's okay. Decrease the preload, right? Because I'm not going to feel that. But if we're at 90 over 50, or 80/42, we're gonna have that every little bit. It's gonna matter. Obviously, penetrated chest trauma, facial anomalies. Why would facial anomalies be a problem? Good seal. Right, good seal. And so, yeah, so sometimes even finding a CPAP mask that fits just right could be a problem. A closed head injury. I'm not sure what would lead you to CPAP unless it affected the respiratory center of the brain and you had some weird respiratory pattern. And an active upper GI bleed and a history of recent gastric surgery. So you don't want to cause a pressure increase to somebody who has a very weak esophagus, or right there where the esophagus attaches to the stomach is a common place for a surgical fix for gastric reflux. So you don't want that. So those are your contraindications. But your big one really would be the inability to protect your own airway. That's your big one. That's the one you'll see a lot. All right. So what we'll do here in just a little while is practice that with a patient. Since we kind of know how, it's kind of simple. Plug it in, turn it up to 15 liters. Have your patient hold the mask while you apply it. All right. Yep. No. All right, so that's CPAP. How far are we going?
6 minutes.
All right, so let's take a break and we'll come back and we'll talk about these airways.
It's 15 our number regardless.
You're not gonna be wrong. You go
Oh,
straight
yeah.
to 15.
Only ask.
Because it says 8 to 10. Right, I go straight to 15.
Okay.
If I'm using it, they'll probably.
Yeah, I mean,
They need somebody.
yeah, if you're going. might as well.
Yeah, I mean,
You gotta be aggressive. I was thinking more like 6, but it didn't work.
Question.
Yeah.
So.
Paramedics.
there is a, even though it's as a paramedic, you have to be checked off on skills that are underneath that, you're always. Yes, it does. So we'll go over that. Okay. Yeah, and then we need to go over that too, because there's a reason why.
Yeah.
I mean, even, well, not even for secretion, it can deflate the stomach. It makes CPR better. Oh. You don't ever see my good field.
That's what Jerry was talking about that one. Suction down there.
Yes.
I know. Was there a size 2 and 1?
Its size is
In bed.
3, 4, and 5.
But still right
They're all
here.
for adults.
I opened it up. I was on question number 9. That little kid, this, picture that kitchen thing I put.
Oh, yeah.
Dude, God damn it, man, I was so pissed by how I'm doing it. This is so annoying.
AEM.
No, I texted him. I said, "I read it." Must be so.
Suction out. They're not gonna keep this.
I respect you.
So this is basically the older. So let me say this. It's a side effect of AEMT. But it is. When down there, actually, she wasn't hypotensive. You were able to get it done. No.
He doesn't.
Microwave heat up.
He was too aggressive. He was too aggressive. Put it in the trash can.
Oh, there's always going to be
Well, I What? I got three. This week. Three. I swear, I just did it. See what you got? I got 3 steps. I do know. It's fine, dude. He just went aggressive. That's all.
Oh, you got that water below the door?
No, I was gonna say that. I was like, wait, what was that? Am I, that was too hot, or did it just?
I love it.
All right, I'll thank you.
I'm trying to. Just grilled chicken wings. Grilled chicken wings. Macaroni pasta. Might make a little. Doesn't feel right.
Well, there were waiting there.
Don't play for that. Come and see the. I enjoy it like that. That's fine. Yeah. I was like, I just want the benefits of your life. Right.
That's the job.
Good.
You just I feel like eating white rice right now. You could. You just try. Go down Real. For sure I did.
You just that.
That's gonna cook last night. Got an exit wound. That's all. Good.
That's fine, Bob.
I don't have no extra. Oh, you say violent. Yeah.
Sucks.
100 calories. You ate that? Dude, the consistency is better than a rice cake. They give us rice cakes. Only 6 ingredients. 250 attached up there. Hey, who's this? A little bit of they got on.
I know, that's why it's so crazy. That's like something. Take a little more time. I bought things on Sunday or Saturday. Well, I put them in the fridge. I didn't know that would ruin them. I'm so trying to feel it. It's like yellow.
Oh, that sucks.
So body place.
Probably, but I put it in, if it's in like a cold part of the ground, it's like sitting out.
I got those donuts.
What?
Donut
No.
features. I like little tiny. What's up, it's what. The nectarines I got. I got. You know, a lot of water.
Looking at this officer, like, how long was
Talk about
this?
the whole like actually go out.
I got both of them. So much of it is hard. It's very amusing.
I don't know. It's just like, oh, I got maybe one of these. All the water. Oh, yeah.
Our chickens are really cheap. They're chickens like
I'll be done by lunch.
Why get like a Costco? Yeah, sorry. It's like all these. Anyways. All these. The only tension is you've got a background. I'll just go.
Oh, I saw it.
I never have kids. That works too.
I like that.
It's a real man.
Okay, y'all listen up. When I say listen up, y'all can hear. I need a Mott, Campbell, Cantrell, Paul, Harris, and Canute. Those the instructor mark.
I told her I would.
Fucking thing.
We're good. Maybe.
Hey, you know what about Alabama? Hey, you know about Alabama? Like, you know that?
We'll say it's you.
Oh, yeah.
What is you?
A lot of them transfer to US. A lot of them transfer to US. Just
Oh, really? Wow.
So, yeah,
I got LVP through whole house. I ran into every bedroom, every back, every closet. It's same porch, always. Yeah, it's the same process. Because it sits on the wall with a piece that come around and landed under the board. And then you have an exact picture. I must have cut that. But I got it though. Not like cutting a piece the right way. I literally cut it 4 times a game. I think you want to invest in it. Yeah, really bad.
Oh, they know what it
Yes,
is.
I had to call behind the door. I can't get under here. I got chicken on my bed.
Then they got,
I divided that.
That ain't bad. That ain't bad. This week's been long, bro. Let me smell your fingers. What do you gotta do?
high school. They already got.
I remember I asked about getting all this stuff. I was like,
4 months later, we realized you're not giving us something. Turns out you actually didn't qualify for this job. That the OG? I know what. That's such a game. Wow, dude. Why don't they sell it like this? That's all. That really hurts. I'm literally gonna get that. That's all.
I'm surprised about that.
Super cold latte. Yeah.
Actually, that's fine.
So Tom Joel list. Joel. I like step number one before making insertion. It feels like you're at home, you know what I mean? You gotta lubricate your that's funny. They really worded that. They worded buttons over here. Wow, man. That really makes me hungry. No, man, I can't do that, but I'm gonna stop and get some as soon as I leave here. So you're saying those are extra cheddar? Wow, a lot extra. He makes an extra cheddar cheeses with a bag of pretzels. Son of a bitch. Dude, I'm going straight to the racetrack. Snacking all the way. Yeah.
Body splash. Make your own bags and still go live.
Every check's
What?
The same thing that's normally wrong with it. He just leaves here and hears his voice driving.
You're a little further away now. That's good. You know, I'm jumping there. I like to make choices now. He'll be back.
Literally here.
Oh, I don't care.
I just implemented this.
Yeah. Okay. I just gotta like, I'm not gonna be like that. I'm gonna turn around.
Did you see the test thing made with protein stuff?
Yeah, I cut it out and put it on.
That's the ingredients now. Testy. Yeah, dude. That's the ingredients. Powdered dicks.
It's the fruity pebble, so it's kind of humble.
Smash cake.
We're fixing to watch another video. This video is going to discuss the LMA. It's going to discuss the King Airway and the Tommy tube. So that's what we're going to watch next. Then after that is over, we're going to get you guys in squad, get you an airway head. I want you as a squad to go through your checkoff sheets, right? So your CPAP and your superblock airway. Practice that for a little while. Then after lunch, we'll come back and we'll do some scenarios based on airway management. That's the plan.
Of the upper jaw.
Oh, hold down there, hero.
Just add it.
He's tatted up.
Actually, that's a sweet.
There, Jones. First time I see him.
That's a no.
That's the merit right there. It's the past 15 minutes.
Huh?
That's the merits for Jones right there. It's the past 15 minutes.
Jones, you there?
I'm here.
All right, here we go.
Yeah, all right.
Hello, my name is Nikolai Yusupov, and in this video, I'd like to show you how to insert 3 devices that are super robotic, an LMA, a combi tube, and a king tube. And I want to also show you some of the important criteria to look at utilizing the manufacturer's guidelines and some of the tips that you could utilize in the field. So first, I'm going to start with LMA. LMA stands for laryngeal mask airway. And this device is sized based on patient's weight. So this one is for a patient between 30 and 50 kilograms, and you're going to put less than 20 mLs of air into the cuff. You notice that I inflated the cuff. The reason why is that I want to show you how it sits. So here I have a cutout mannequin. This is your trachea and this is your esophagus. And this airway sits in the upper esophageal sphincter. This is where it's going to meet resistance. So when it sits properly, it will look like so. This here portion is where the oxygen will come through and it will go into the laryngeal inlet, which is this part here. So once more, once it's seated properly, this is how it's going to look. Now, this device will not protect from aspiration. So if the patient were to vomit, it may go into the trachea because, as you can see, it doesn't isolate like an endotracheal tube would. Now, how are you going to insert this device? So step number 1, pick the appropriate size. And for this patient, we're going to say we already pre-oxygenated them, place them on the monitor and monitoring their vital signs, pulse oximeter, and end-tidal CO2. So the manufacturer recommends is to deflate the cup fully while the mask is lying flat. So what I'm going to do is showing you here, I'm placing LMA down. Ideally, you want to use a surface of the packaging that it comes with. And you want to deflate the mask and notice there's no ridges or obstructions that will give me resistance when I'm inserted. Then I already said that I'm going to put 20 mLs of air into this device. The way I'm going to hold this is like a pen. You notice I'm placing my index finger in between the cuff and the tube. So the junction of the cuff and the tube is where my index finger sits. And I'm going to insert it with this motion down up against the hard palate into the hypopharynx, and my upper esophageal sphincter is going to be the point where I should meet resistance, and that's where I'm going to stop. Another important thing is you need a water-soluble lubricant. Now, very important that you do not place it in here. The reason why is that you are going to placing it on the posterior surface. So placing it on the front first may occlude where the oxygen goes through, and 2, patient may aspirate your lubricant and you do not want it. So all you really need is you need to place a bolus amount in the back of the LMA. You don't have to work it around your tube. This will suffice. The next thing that I'm going to do is I'm going to hold the head in this position. You actually want to position your patient in a sniffing position or intubation position for this device. And I'm going to go ahead and slide this over the hard palate of the patient. And I'm doing a counter pressure up against this arm. So as I'm inserting, I'm putting pressure. Now you may hear clicking sounds of the upper jaw. And this mannequin is made for intubation. So when the handle rocks back, you hear the clicking sounds of the teeth. But if you hear it in this instance, that's okay because I'm actually pressing it up against the hard palate to insert it properly. In addition, with this device, you're not going to see exaggerated chest rise on this mannequin, right? But for the patient, you will see chest rise utilizing this device. So lift the back of the occiput, lubricate the hard palate a little bit, and then as I'm inserting, I'm making sure it doesn't fold onto itself, and I'm actually forcing my finger up against the hard palate as I am going down up until I meet resistance, and I'm looking down in the airway, and I'm trying to see if there's any kink or it's folding onto itself. I did not see it happen, right? Once I have placed it like so, you notice I'm no longer holding the tube in place, and you don't need to do that because this is not an endotracheal tube. Endotracheal tube sits in the trachea, so you have to position the patient, use a laryngoscope, and go through a lot of procedures. So in the tracheal tube, you must hold in place. This device you don't want to hold in place. And in addition, when I'm going to inflate it, I want the shape of my distal cuff to take normal curvature of the patient's mouth. And I wanted to kind of see the tube pop up. This is why I don't want to hold it. We said less than 20 mLs that I'm going to put in. Right, and you notice it now has sealed. In the OR, they would use a pressure cuff. They would actually place a pressure cuff device and see the centimeters of water pressure. You don't want to exceed 60 centimeters of water pressure. So amount of volume you place in is totally different from the pressure that's exerted against the soft tissues. So I put less than 20 per the manufacturer's instruction. I place my cuff pressure and it should be less than 60. Then I'm going to go ahead and connect my Untitled CO2 meter. And I'm going to go ahead and connect my bag valve mask device. And I'm going to slowly squeeze the bag. You notice I have chest rise on the patient. Yeah, it's not going to be exaggerated, but with this device, you're not going to have an exaggerated movement. So how far deep down you're going to insert up until the upper esophageal sphincter, you will meet resistance, you're going to stop. Right? And we're going to verify both the objective data, which is Untitled CO2 and lung sounds, as our subjective data and negative epigastric sounds. So this device is, again, I said, there's a supraglottic airway, will not prevent aspiration of the gastric contents, right? So, and I also want to show you where the oxygen and ventilation actually comes through it. So I'm going to deflate my cuff, take this out. So I'm going to put my glove on it so that you can see where your oxygen is actually coming out. So it's coming out from these ridges that you see here. Right? The next device that I'm going to talk about is the combi tube. Now, the combi tube, I've seen students have a lot of issue with. The reason why is that you have now two tubes, and there's often confusion which is which, right? So let's go through all the tubes first. So first of all, we have this tube marked number 1. And this, when you ventilate through this tube, the oxygen and the air is coming out through these holes or these fenestrations. It does not come out from the distal end. When you ventilate through this tube, it will come out from the distal end. And I'm just going to show you this so that you can see. So in the initial part, number 1, the air is coming out through these holes. It will not come out through the distal opening. Nothing. The moment I switch to tube number 2, there's nothing that's coming out through here, through these openings, through these fenestrations. But the moment I put my glove on the distal end, you notice, right, how it's inflating. So what's the purpose of this? The purpose of this is as follows. This device will sit 90% of the time in the esophagus, right? And the distal balloon will occlude the esophagus, and the proximal balloon will occlude the oral pharynx. And the oxygen will come in through these inlets here. Now, what's important to note is that sometimes inadvertently, this tube may go into your trachea. So if you do not get chest rise ventilating through tube number 1, and there's no lung sounds, you're going to go to tube number 2 because perhaps you inadvertently placed it in the trachea. But 90% of the time, it goes into the esophageal space. Now, you have 2 pilot balloons, and they note how much volume of air you're going to place in them. So tube number 1 has 100 ml of air. This tube is for an adult, usually greater than 6 feet in height. So it's height-based. And the other balloon will say 15 mL. So that's the amount of air you're going to put in. And these 2 demarcations here is where your central incisors of the upper jaw will be. So upper teeth in between these 2 marks. If the patient has no teeth, you're going to use the soft tissue to mark where the insertion is. How are we going to place this device? So first, I'm going to go ahead and deflate my cuffs. And this device is used when you cannot intubate the patient and you cannot ventilate the patient with a BVM device. Oftentimes, paramedics use it as a rescue airway where they couldn't intubate. And it's used in cardiac arrest here as the definitive airway because sometimes you may not be able to intubate. So you will use in cardiac arrest situation to provide advanced airway in place. So let me deflate the cuffs and show you how it looks. Now, if a little tip I'll give you, if the patient is getting active CPR and BLS has already pumped a lot of air into the stomach, what may happen is, as you saw from tube number 2, it comes directly from this inlet, right, to this. And if you place this in and they're doing compressions, you may get sprayed with all their gastric contents. That's why the manufacturer places this adapter. This is essentially called aspiration arm. And what you want to do is, upon placement, if active CPR is going on, you want to close off tube number 2 so that you do not get sprayed. And you want to point this away from you, right? So if the gastric contents do come up, you're not going to get splashed in the face. Again, only for if active CPR is ongoing. You're also going to need to lubricate this tube. Do not lubricate the front end of it because you're going to close the fenestration, the openings. So you really just lubricate the tip of this, right, and the back, so to facilitate the insertion. How will you place the patient? So you'll place the patient in a neutral position for this. You don't have to elevate the head to do it. I see a lot of times students connect syringes so they're dangling down. I don't advocate doing this because it will be in your way when you're placing this. You see how cumbersome this becomes? So I don't connect my syringes. All I do is I just have it ready at 100 ml, at 15 ml. You can use one syringe if you so choose, right? And then what I'm going to do is I'm going to perform a jaw lift. Unlike a jaw thrust, so jaw thrust is you use both hands to elevate the mandible up. A jaw lift is essentially use your thumb to find the tongue and you're lifting the jaw upward. Lifting it like so will facilitate insertion of your combi tube. So I'll hold my combi tube in this hand and you never want to jam it down. So lubricate, right? Jaw lift, come from the side, and you're going to insert it down and until the upper incisors are in between these two marks. Now that I'm satisfied, again, I'm not going to hold this in place. This is not an endotracheal tube. Ideally, it goes into esophagus. And 2, when I inflate my cuffs, I wanted to take normal curvature of the airway. So I'm going to first inflate the 100 ml balloon, which is noted here, with 100 mLs of air. And you notice how it took the natural curvature of the patient, right? Or in this instance, the mannequin. Here I'm going to put 15. I have this in place if the CPR was ongoing. If the CPR wasn't ongoing, you don't have to have this diverter in place. Then I'm going to go ahead and place my Untitled CO2. And I'm going to verify, right, with the balloon that reads number 1. So I have goose chest rise, right? I verify my Untitled CO2 and I auscultate my lung sounds for subjective data, right? There's no gastric insufflation. Do I have to check balloon number 2? No, I don't, because I know I have a placed in where? I have it placed in the esophagus. And if you see, if I ventilate this balloon here, the pouch of the stomach will start to inflate. Okay? In addition, what can you use this second port for, right? So the first port is used for ventilating your patient. Do not close off the second port. What you can do is, if the patient needs gastric suctioning, you can place, right, your adapter here, and then what you can employ is you can utilize NG or OG tube in order to suction. How would you size this? Ideally, the way you would, they state in the book is from the mouth of the nose around the earlobe to the xiphoid process, but because we have a tube which is longer, right, than your nose and the mouth, so you want to size it from the tube around the ear to the xiphoid process. And then what you're going to do is you're going to utilize this as your suctioning device to decompress the stomach. So insert this up until the appropriate depth marking. You're going to connect this to your suction unit and you're going to suction on the way out, decompressing the stomach contents. I'll leave this in place so that the vomit doesn't go on you and you are protected. and you're going to ventilate through this port here. When you're done with this device and you have confirmed, you can secure it, right, with the Thomas tube holder, as you can secure it with all your devices that I have on my table, the supraglottic devices. Now I'm going to deflate it, and I'm going to show you the final one with that King airway in place. So the King is essentially also a rescue airway, and unlike the combi tube, it only has one tube that you can ventilate through. Now you notice there's two types. There's King LTSD and there's King LTD. So LTSD has a suction in the back of it. So what is this suction used for? So the suction is used for, so again, to decompress the stomach contents. And you can suction through the back lumen here, and it will come out through this end. There's no oxygen that's being delivered through this opening here. If I connect my BVM and I ventilate and I connect my glove to the distal cuff, you notice it does not inflate. All your oxygen is coming through this inlet here. Okay, and the King LTD does not have the suction in the back. How much air are you going to place? So it tells you between 50 and 70 mLs of air. This for an adult is sized based on height. For the pediatric is sized based on weight. I'm going to go ahead and deflate my balloons prior to insertion. So the manufacturer recommends 50 to 70. And if you look at their manual, they'll include a 60 cc syringe and they'll say, actually put all of it in here. And it makes sense because it's between 50 and 70 and we have a 60 cc syringe, so it'll be right in the middle. How are you going to place this? So again, you're going to utilize a lubricant. And again, you don't want to lubricate the front end of it. The reason why this is where oxygen is coming in. And again, you don't want aspiration. So just the tip and the posterior of the tube. I'm again going to perform a jaw lift like you saw with a combi tube and come in from the side. But unlike a combi tube where we placed it until the two demarcations markings, I'm going to put this in all the way up until the adapter is at the teeth. And then I'm going to inflate my cuffs and I'm going to withdraw it while I ventilate to see optimal chest rise. So you'll say, why? What's the reasoning that you go all the way in and then inflate and pull back? And the reasoning for this, it's much easier to pull back. And then if you have air leak, to again put a few more cc's of air to close an air leak, as opposed to if you went too shallow, you then have to deflate your cuffs fully and then only then advance. So there's more steps if you put shallow. So it's faster if you go all the way in and pull back to see that. So we're going to put 60 cc's of air, jaw lift from the side, and then go all the way in until the adapter is at the teeth. I then I'm not going to hold the tube in place because again I want to take it normal shape. I'm going to put 60 cc over here. And you notice again, it molded to the airway. I'm then going to connect my Untitled CO2 detector, which I have placed on the table, and my BVM. And you're not going to see an immediate chest rise. And I explained this because I'm going to slowly advance the tube upward until I see optimal chest rise. And you could feel it. You'll have ease of back compliance once you regain. So you notice once I regain chest rise, the compliance on my back improved drastically. I'm going to then listen if I have any air leaks, only put 60 cc's of air. If I have any air leaks, I will then again may correct that, putting maybe 5 or 10 more. And I'm going to verify my placement objectively with my Untitled CO2 and also auscultating lung sounds to see that I have presence of lung sounds in all fields. And once I've fully confirmed, I'm going to utilize my Thomas tube holder to essentially secure it. Far too often, I see this placed inappropriately. So how would you place this device? So if my partner is ventilating the patient, what you want to do is you want to position this mouthpiece aperture facing towards the feet always. Anyone who tells you it's supposed to be upside down so you can read Thomas, do not know what they're talking about. So tell them to watch my video and read manufacturer's guidelines. And then what I'm going to do is place this under the patient's head. This is called a V wedge because it resembles a V. I'm going to then insert my tube into the V wedge, like so. Once it's in the V wedge, I'm not going to tighten my screw. I'm going to then position my bite block into the patient, making sure that the lips, right, are not caught when I'm doing that. I'm going to use my slider to assist me in securing my strap. Once it's in place, I can take this off. I no longer need it. And I'm going to secure my device. I first want to verify that my Velcro strap is securely on the patient, right? And I'm satisfied only then, and I'm going to go ahead and secure my screw ball in place. The reason why is that I don't want to be moving it about when I'm doing this. I also want to be careful that you don't put it too tight to occlude the tube. This will prevent this from kicking if the patients were to start biting on the tube. But this is how you would employ all these three devices in order to secure the patient's airway.
We're going to walk through how to do a rapid sequence intubation. The first thing you want to do once you have your patient is to make sure that they have 2 functioning IVs. That's what you're going to use to push the medication as well as any IV fluids you may need for support. Oxygen, right?
Nice.
Dude, he has some nice tattoos, but.
Yeah, his tats look dope. He took really fucking fast.
Man, that was a sleeve, bro.
That was
a full-on sleeve. You can take those tattoos off. I will.
Hey, you can hit them lights though.
I don't like the aura that's.
No.
Bro, the natural sun.
The aura is taking me out. Oh, yeah. Dude, that light's off. I fucking struggled so bad.
Never had cheap ones?
That's why my wife was that too. She can watch a movie with her. There were lights on. And then lights on. I was watching a movie. Oh, dude.
Every
Good.
time.
I'll go sleep with her. You can watch the movie tomorrow. Come on, bitches. And I'll fall asleep. Me and your girlfriend, we can fucking rack out. Y'all can stay up all night. She, my wife stayed up all night long.
She'll even pick it. Like, let's watch this. I'll be like, all right, you're gonna fall asleep. No, I won't. And she'll get comfortable.
Dude.
Like, just sit up.
All right.
That's me. I'm out. I'll make it like 14 minutes.
All right, so here we got, what we're gonna do is this, I've got basically 5 manuals, right? So I'm gonna put 2 squads up here on the simulator mannequin. Well, 2 squads back here with those 2 airway heads. And I'd like to have the last 2 squads in the actual classroom side. That way we don't have people screaming and hollering and carrying on. And let's practice putting these in. We're probably gonna need, somebody's gonna need to bring their textbook, right? Because if you're asking me what the concrete figures are, in your book. So start getting used to reference in your textbook. Start pulling this information out. So we got CPAP, the Igels, LMA, and we got a few of these games that we can play with. But your big thing, what you're going to use for testing is Igel. Be thankful. No, nothing to inflate. I'm glad. What we'll do is up here on this one, I have it set up for people to rotate through. We'll have entitled CO2 that'll be connected to the Igel. You learn how that works. That's about it. Do we need to take a break before we go to the slabs? Definitely. All right. So let's, I got 10:30. So let me do it. So I will, did I tell you what squads are where?
No, sir.
So
just
squad
two,
1
two,
and
two.
2 up here,
Yep.
3 and 4 back there, 5 and 6 in the lab.
Sir, is this?
What? Sounds like a plan.
I was like, wait, what comes up here?
I'm dying, man.
Dixon is awesome. He's like the hidden black. Because he's always attentive. You'll never, yeah, always attentive.
I can do all that work. Are you sure about that?
Yeah. Every time I've ever called him Dixon, he's always bam, off the answer. So
He's like Fergie.
he is. He's good. All right, so y'all grab you when you get situated. Here's the stuff.
We're doing all three.
What?
I didn't know we could take pictures.
Yeah, we're gonna do everything. We're gonna do it all over here. You know what we need? All of it. Where's that? You bring that table? We'll bring this table over here.
That or I recently just became very obsessed with China. I want to go see the Great Wall.
What are you associated with this week? Are you still is squad 6?
Is that okay?
Yeah. Yeah. All right. They are very similar. Well, the key I think we should go. All right, let's see here.
What I want to do.
Read the way they're not even the contract. Sorry, around your like performance insertion. Step 1. Lubricating the step for your life. I mean, think about it. It's like a pop.
We're gonna say he's gonna be like a 4 on that, I think. Let's see. So I can't remember which one. This one is what they found with that. So we'll go down. 3.
Oh, yeah, one percent. Oh.
Got an Igel belt, ELS. Got a banana home, which is just a ELS.
You like the banana?
Those, yeah.
I just use for.
We need some other strength. All right. CPAP, that's good there.
Oh, God.
So I just get like, I get like 10%, so I just grab like a couple of these, whatever.
Only.
I'll go check it out.
Weird.
I like it. I've really got it before. Like, 2 times in my birthday company. I got it. They got it. 2 grams of turkey. Yeah, that was my first.
I got the new one down now. Closer, we got 20. Not bad.
Yeah. I like. I'm born at 6'2". That's about Monday.
Good.
Walking on it out there. Yeah, we're only getting, but I'm thinking that actually I might wait.
Dude, I'll fill you up like that.
Correct, and then just kind of reassess it. And
Well, I'm gonna be in June. I'm afraid to come back. Too much science. I'll be the same.
That's how.
That run is.
One, 2, 3.
Nope, no, you're not.
No.
I seen this video the other day, like how Snoop Dogg says his name in like every song that he ever made. And like what if like when he started changing his name, he went back to all those old songs and changed it in the song and how it wouldn't sound good at all.
Right, what's not good at all?
Yeah.
That was the part.
Snoop lying at the dump.
Snoop 9.
You got so many names you call yourself? Oh, fuck it. Nothing beats fucking Metal World Peace then.
Metal World Peace. Oh, the name.
Yeah, nothing beats that, bro. Nothing.
It's there you go. It's learning.
There it is. Uh-huh. Whoa, whoa, whoa. Huh? We've been on a break, right?
All right, so, you check off sheets up here, make sure you're going by the correct step.
Your chair, you got it, check off.
Yeah, I did. I put one on your desk. No eating in the classroom. Please. I don't know how y'all did it in the Marine Corps. But here at the fire department, we follow rules and regulations. He didn't say nothing either. Oh, he said something, but he didn't say something out loud. No, he said something.
You're up here.
Did you not just listen to this whole
This is
time?
this one, right?
Listen, don't listen.
I don't listen.
Be observed.
What is this for?
That's for Entitled CO2. We'll go over that here in just a little while.
Well, it has to keep it real.
Because I don't want to get all
Someone stole it.
Put it in here.
then pretty much you're just grabbing it.
No, it's spray. I'm trying to make it bigger. Has a line for us.
Yeah, so is that not fit in there or something? So sometimes some of these don't fit. Go down.
That black line for the.
Oh, we got head straps. Let me see if you guys are gonna jump back.
I mean, about everyone.
I'm like, I don't go bird watching. I just know birds.
It just happened, you know.
Hey guys, you're gonna need your jump bag, your two bags.
Balls to the wall. I'll look for a nebulizer.
I just told them, these guys next door, I'll tell y'all too, this is a good time to go through your bag. You know what I mean? Go through your bag, make sure your stuff's there, you know, all that, so that this afternoon, it's all ready to roll.
We need a net mash.
Okay, yeah, I saw that.
Ours is missing.
I saw that
It's
yesterday.
been there the entire year.
Until you needed it.
Well, it's been there every time we checked it. And when we opened the, airway pouch.
Is your bag out here somewhere?
It's done. I'll go get you that. We just assumed it was still in there.
Ready to make it into
That's the only part I know.
After that.
Go.
That's working. He's ready.
We're not calling, bro. No, we're not calling. Whatever we call it. Stay in the side, you know.
You're sitting there, what's that? You look like one of this way you normally do. What?
So here's another
Leave the gloves up.
There's someone definitely dangerous, bro. Hey, cool.
I'll show you about in the smallest.
So we have. Furthermore, she's. Probably say it's really medium. Yeah. Oxygen tube. And so what happened was.
That's pretty.
That's why I was here. What the heck?
Breast cancer awareness.
There you go.
This is why I'm questioning when people get me wrong.
He's got looking through his eyes.
Old school. Outdated parts.
It took me 10 minutes. Oh, wow, look at this.
Marcy, you're doing like a neutral position.
Oh. Yeah. Catch up.
Right. No, yeah. I think it's.
We're trying to organize.
Try bagging them right here and see if you get chest raised.
Someone says.
I think it's in the right. Grab this bag from our. We need a mask.
This for?
Mask? Yeah. Do we have?
Okay. It was here.
We probably have to be on. That might be what it is.
No two can do it for that, but for these CPAPs, they just slide in and then work.
Or we got a crisis.
Ours is all right. I mean, I haven't used that brand in so long, right? But I have used that brand before and I don't remember anything going over that. So it was
Yeah, like,
it is that easy. And even if I'm missing something on that one,
Yeah, that's what you do. I think.
it is that easy. There's nothing besides a mask and that. And so, and nowadays, you don't have to put that. Built in. So you have to really just put the mask.
I just make sure everything's together.
Yeah.
Let's make up their bug.
Yeah. So I went back through it. We were down Go check the check out mine.
Oh, it's always be shit.
Yeah, he shipped it.
Or C shift.
What did he say? That's just
It is, oh yeah, it's the weight. Yeah. It should say on the outside of the package, pounds, but it might say kilograms. If it doesn't multiply by 2.
what's ever on that package. God, I wish we were on the metric system. It makes life so much better. Because we're so used to it. It's like, we would say, oh, he's 8 kilograms. and I'm like,
Yeah.
But now I gotta teach my kid, because nobody ever taught me, trying to college. So, the metric system.
You need to turn this on to get like, try to fall and stuff like that.
You do, what I would ask you to do, so that we don't pop his lungs, is to keep his respiratory rate around 4, keep it low.
Okay.
So yeah,
Thank you.
so it'll even tell you if you're administering the proper amount of air.
Did I put on this button on the side?
Yeah. And when it starts blinking, it fixes it.
Oh, gotcha.
I got all of them. So when you bagged him on this chest rise call?
There's
Huh? So did you go smaller?
No, I tried to do just the bag and stuff.
Should rise. Oh, you know why?
Nice. What's true rate about 40, so.
So, you've got it.
So when you put it in, it should have chest rise and fall. The bars?
So, how do you tell which one is which? As far as GP goes?
You gotta come around, start asking us questions.
Getting you.
Yeah, but there's more.
Yeah.
During the scenario, just pull it all out.
Hey, can you hand me the, your things,
Yeah, that's
good.
So. Those should drop. Right.
But
What's the purpose?
stop it.
All of them, they all got aggressive.
What size is that on them?
Five.
Yeah, I remember everything you do. Pop the one in. That's about
You can use these. You can, yeah, okay. Well, up there on the, everything in the playground.
that's the cheap one right there.
I don't know, y'all check it.
Somebody like that.
Yes. Here is a beeping now. It actually works. Well, the thing won't fall out on you every 5 minutes. All right, we got chest run.
Yes.
It's rising now.
Dude, you heard it first. Yeah, it didn't.
We got chest rise and fall. There we go. Pull back on it. Oh,
Hey, it's looking worse. What's the purpose?
Pull back on it, so.
pull back on it. It gets a better seal.
Oh.
It isn't too far. Oh, so you don't do
Why do
that.
all these airways have?
Oh, yeah, nice.
Yeah, because a couple of things. One, you don't want the patient to aspirate. Sometimes they can still aspirate because this is subglottic. It's just above the trachea. And so if they're vomiting, you want a way to get it out. But the other thing is, we're bagging them with this device. We're gonna have we're gonna have some air going down the esophagus, get into the stomach. And so we want to reduce that chance of aspiration. So we can actually hook a suction device to this, and it will keep the stomach deflated.
So it's more for suctioning excess air out of those vessels than
So try it.
anything else,
Right.
anything solid.
Yeah, we're not trying to like, empty all the gas out.
Okay.
We're basically trying to get air out, but if they happen to start aspirating, then let's get enough out where it doesn't come up anymore.
Okay. So basically, so here's your, this is your tray. The air is 45, right?
Yeah, but depending on your seal, you might maybe getting
Some of it might.
air going in.
Yeah,
It does.
Right.
This is how much air goes in Insertion, correct?
They have the hooks. 45 and 6.
Yeah.
Okay.
When you guys doing that?
OPAs.
Check this out. Oh, here we go. Hold on. And then you go mask here with.
Oh, you know, we don't have.
That's what they
did.
did.
Well, we made that. Doing good. Nice.
We're going to put it.
Hold on, I'm trying to show you something.
Oh, I didn't think so.
That's what a check off. So it's on the box. You want to pass.
It's from a truck, I won't give a shit.
Nice.
Here, you gotta make sure you get all the air.
Now you get the proper seal.
Yeah.
Over.
No.
Oh.
He's still getting oxygen.
I mean, yeah, technically it is.
I think I said that. He's still getting oxygen.
Wow. Look at this picture.
I know. We're supposed to be volumes on. Oh, no.
Oh, you gotta do for it. I was seeing you check. Last time it was like a recipe.
You're bringing 40,000.
Yeah, just keep some of that down and like, If you had to, I think you
With Wallace.
It's like my balls.
He's on ADP.
So we just put it in like that.
I can't hear. And that one I just don't trust. I'll all send the same. I got a shirt.
You got to wear rubber.
I don't think I've tried it.
That is true.
You got time. I wish you would.
The king airway.
Hey, let me try. Wake up. All right, so this one.
Good. Thank you yourself first.
It's subtle.
Yeah, you gotta
like,
put it in
you
your
get
phone.
YouTube videos, right? And I'll show you like
Cleaned up.
at a certain point they'll start to blend together. That's what I got.
Those videos I watch.
And then when it's this thing, I'll be like, I don't know if this is supposed to sound like fractures or normal. Rather, at this point, I still want you to look at more, like, just tell me what it sounds. Okay. Most of this I've want to learn just on my first probation.
Yeah.
You gotta push it on the job. Is going to teach more than these classes.
Yeah, during clinical. We use like rails.
Push and connect
Push.
electrodes.
Just touch me. And it's action. Okay, so what's the pushing? Rails sound like what? It's supposed to practice.
Extra small.
Connect
Let me try that.
electrodes.
Oh, just like the YouTube.
Connect electrodes.
Is that how we play?
I got it.
Pumps in my balls when I go over. Just squeeze your balls and they pump your dick up.
Yeah.
I got one over the house.
People in saline. Balls.
Connect
It's
electrodes.
like it's in the scrotum. Hang on, maybe just pump it up.
No, I
Testes.
Let me try that eye gel.
Put it in my
This one.
Connect electrodes.
So the difference between the Igel and the one the one you said was the king, right?
Yeah, the king's only 2 balls.
Oh, and then what's that one?
That element in my ass.
So the difference between that one.
Security device.
Sounds pretty
Way down.
So the difference between those two that
The trilogy that they just
that are on the picture right now
Oh, yeah.
is just the fact that
Is that-
non-Igel one.
Yes. Like calling in other assassins.
Yeah.
It also was a good
Got a
story.
bag.
Just talking about
Assassin's Creed 2.
Oh, that's my favorite.
Wasn't it just
I think I came
So here's something.
I put black.
Broke it.
Problematic.
That's why we're talking about. I know, that's why we're talking about.
I love that.
It just got Revelations. Yeah, I played half a quarter and I put all that bomb making bullshit.
You guys want to practice?
Yeah,
You guys wanna practice?
I already got that. I already got those.
So Igel's basically the same.
The evidence. There's no. Which way does it go?
Push analog. Connect electrodes.
Nope.
Got the almonds. No, it's high end. It's like his block.
Yeah, you know.
Oh, you're an accessories guy. You're an accessories guy. You like accessories.
Does he use his iPhone for directions? Oh, no, he's got his Garmin up there on the dash.
Watch sometimes, so program. What I'm saying is, I'm just saying that.
Watch?
Hell no.
Looks like a Kindle.
Yeah, dude, I can actually.
You better be able to.
Get in on.
Did y'all take that? That's why I don't want one.
I was thinking. I've got an Apple Watch, but it's been dead for like, can't wear it.
Oh, yeah, this is the.
Me, by the way, I got it.
I think there's probably more than.
I was gonna get an Apple Watch, but 2 weeks before I got this, my second I got the thing, so I need all of
I'm just playing.
Olive oil.
We don't have. Yeah, I think mine's I've been putting a lot of lube on it.
put a lot of lube on you.
Oh, I like how it gets all pumped like that. It's a mesmerized. It's all. What was the other one? I think I know what you're talking about. Pushing the head. I want to say copies you got us.
For practice.
Oh, the
That's the other one.
What other one?
These are games you're talking about.
I don't know.
Oh, we keep talking about
the airway back.
We gotta get these answers.
Yeah, someone go get the airway back.
Yeah, I should bring a gay friend. Let's have all the shit we want.
We have to make sure we're not with you.
Clearly, you're so afraid.
Talk them all. Talk them all.
Is that your entitled?
Yeah, I wonder if you just listen to
Igel.
Dude, you're gonna owe the county $40,000.
But that against we can. Oh, no, I had.
Yeah.
Oh,
The mobile camera a little too wet. Not a lot of social. Jeremy? I have a problem. Mumble right. It's your book, eh?
Just killing them.
What is that? 1 every 6 seconds. That's how else is it?
This is gonna be the difference between.
Why?
Jones, you hear me now?
I can hear it now.
All right, good. Okay,
You just push down.
yeah, don't put anything sticky on it, mess up the skin.
Okay.
But
We're trying to impress you.
Take the electric, take what you got those buttons. Yeah, pop your electric, it pops in right there.
Is this the fourth? Is this the afternoon one we were talking about?
Are we supposed to be doing a pilot checklist? Are we really?
That's where you get tested.
When we get
Only for
tested?
Igel though, so. And you just wanted to
Left
see.
leg.
You still need to do.
We can do it as a group after we're done kind of.
Right.
We can just do one.
So remember, it was suction. Where's the capnography?
And after.
It's on there. On where? Is it connected to our super? Reads your exhaled CO2.
Exhale. I do it in some of this.
And what they're saying is
35. What do you call it?
it's 35 to 45 is normal.
Too high would mean that you were alkaline.
Let's look up the,
We did. Yeah, we do.
That's not wrong.
I got some good stuff on my third minutes.
Yeah. We have one something.
All right, let me run it.
Where's the,
Yeah, probably. I'm gonna run this.
Do we use these in the capital?
I'll take that out.
oh, we don't use topic two, we use those.
Hey, you want me to tell you afterwards what you missed, or you want me to grade you as you go? I'm not ready for that. Just tell me what I'm missing as I do. You should do it.
Hey, Matt. It's the apnea alarm.
Oh,
I sound like I'm trying to go.
Okay. You got Captain Obvious there. Captain Obvious, Captain Obvious.
Put it in deep bed.
good.
Not it.
Maybe
Right,
like
what's
that.
that called?
Yeah, probably. Yep. Ask Morris. Trevor Morris. That's Captain Obvious, that simple?
It is that simple. So you can leave it
That's
like
it.
that,
Yeah,
if you want to, just insert it, it's already on.
Is it an extra piece or you just plugging the cord?
No, it's an extra piece, you just take that, you put it where your BVM goes, and then it's gonna leave you another place where your BVM lands on that.
Is there another? Remember when you go to
That's more like cash
North, read at least 10. You're doing adequate impressions. That's what matters. So we need
Make that a spell.
Can we?
Can we go to my island?
Yeah, if you don't blow their stomach contents into their liver, you sure could.
God bless
It'll just
America.
filter them out.
God bless London.
Oh, I'm 100%
Campbell's gonna go through it. We're gonna grade.
Don't break it.
Alton, are you Asian?
I don't know.
He likes Asians.
No, I'm not.
He likes little redhead Asian boys.
No, but you know what I've never seen before? A black Asian.
Wrong way. You need to get out.
I've seen
They're called
They're
blazers.
called Asians, Dad.
All my good friends from high school.
I don't feel so.
Well, I know. So. It says bagging, right?
Yeah.
But just so you know, which I'm sure you did this. Select checks and simple equipment. BVM and mass reservoir, oxygen. Get your oxygen. Airway adjuncts. Got it. Suction. Got your suction ready?
Boys, no, only.
That's probably the only thing you missed. This will be my section. All right. Make sure you got your super broad ready, your capnography ready. Yeah, it's already looked at. Cool. PE manually opens the airway. Yeah, open it. I dig them out through. Ventilate. Attaches pulse oximeter. I know it's SpO2.
It's only.
It says 0%.
It says pre-oxygenate patient. I guess. And then so I'll get my device and I'll communicate in for back end. Right. And then they're like 1%. Performs a jump tall, provides a tongue jaw lift. Secures.
You guys are using hours. So I think you're supposed to just cross. When I did it on my third rise, they did it cross.
You guys still need the map?
Hey, Jones, you there?
No.
Jones.
I'm here.
All right.
What are you doing?
I'm watching y'all.
Are you?
You say I don't have to be?
I'm just kidding.
Auscultation bilaterally. So you gotta listen to the quadrants while someone else, I guess, bags. Make sure you're not doing gastric inflation. Make sure you're doing
So what would
it sound like?
Why can't I see you, Joe?
Let's do something.
I never even talked to you.
Why do you want to see me, Dixon?
Because you cute.
Christian.
That's it out loud.
Hey, don't be calling my first name, boy. Yeah, but see me.
It sounds like lung sounds. Relates at proper rate volume while observing.
So is the rate, you said it was like 6 seconds still? And if you don't have like advanced there, like 2 and 30.
Ventilates patient at a rate of.
That's area, I need to find 6 seconds. Yeah, but I'm saying that one was 30 or 2.
Yeah. So while they're just pumping the chest, you're just maybe 5 to 6 seconds.
Yeah, with that.
That's so much easier.
It's always 6 seconds, right?
All right. Well,
Not when it's 32 though. It's more like- No, I know. For CPR.
Yeah, like say here one by one.
This. I'm sure he already has them bigger than most.
Probably so. That'd be good. It look like what.
Your sees where it's at.
It's not gonna be at the But secondly, the way you talk, yeah, you're fine.
Sleep on that baby. You don't need legs. Yours what they want. Yeah, I knew it did.
Like, I want to do it for me, because that way I'll.
You should Coca-Cola.
Like we saw some mud there. She didn't buy any word. I seen the word mud. I've never seen that. Now it's like, oh no, Lord.
So all the
I
bugs.
have to see it. I have to be able to read it myself with my eyes. I can't listen.
I'm gonna just do the PowerPoint on my laptop. We're gonna have to come to school and just like couple notes.
What's going on? That's like,
Yeah, I'd like to watch some.
are you wiping up?
No.
Sounds like you start EVM to make sure that Untitled hooked up.
Oh, yeah.
He does. That tilt, or do the proper head.
Press the water.
Do you get spoke?
Join the stage. Yeah, you got your equipment, you got your OT. She's like, join the stage right there. Do a line and do all part.
Right. Suction ready.
Yeah.
Okay, first step is.
That's same.
All right, you got a patient. Shallow respiration. Is it like a highway right behind the place? Like these woods and a highway?
So, okay, you said?
It's like a T-shaped building, right?
It's like a complex. Complex. You got not on should be a bonnet. You put it in, screw it.
What you doing wrong?
I want to work more.
I did tell you. All right, great. What's gonna be all the way? All right, you ventilate your gun, your foot, or you're gonna go in the section.
Yeah, I feel myself.
I did that one time yesterday.
All bag and.
I did.
I have to do the preceptor, the right
I don't know why.
That's a good idea.
Because it talks about food rides.
It's dumb. You can well over there. You can take it.
Are the tests easy?
Stupid. I didn't know. Oh, right. He first went to
Yeah.
Okay, cool. Yeah,
I'll
just look for
$100.
No, I just need to do 800 and then.
Oh, good.
Let's do by Sunday.
Dog is
Yes, you should have shipped them out. Yeah, they're due Sunday. It says right there next to, everything's due. Hasn't due.
It's big though.
Sorry. We put your ALS cards in? No, online.
Yeah.
You get it online, they print it out. Like, you can look at it, you can do that. There's a whole thing.
Did you interact with?
You're shipping it over.
Yeah, you're right.
For the bed, but I don't.
I want you to bag them first.
Start
I
with
want you to-
I think I'm trying to say, test really hard.
That one's 6 hours.
The other one is 12 hours.
It's, I don't know what that is, but is it like you can find the answers online or not?
Yeah.
You need to pay badge on.
The FEMA one I got all done.
You do it when you figure it out.
I haven't found the
You know what you do? Highlight the question, right click, search Google.
I have, and then put it out. I'll do that one. And I'll look my questions up, and then there's 0 to 0.
Some of the air is gonna go into your gas. Down here,
So you
use that suction.
Save that shit.
You know when you drive, the fucking fuck out in more water. When you have a super dry.
So once you put the advanced in, it's when you take the one side.
Check to make sure you actually.
And then you'll hear it.
Yeah, ventilate the patient and confirm ventilation. And proper insertion together. Auscultation bilaterally of the gas. So when you do that, after you secure it and start that, so once you secure it, and then all bag.
Y'all won't waste the money I done spend. Y'all want to give
You wanna go, you guys wanna practice this real quick? Like, we'll go by the, we'll go by the checklist that.
You have to.
That one's
I think it's gonna take them out. Yeah, I don't think it's.
Why are you smiling?
Do you like them?
You'll see this guy. Here in the stomach. So listen to the stomach. Wow.
Got auto.
Punching. So if you can get here,
All right, I'll kind of guide you.
so now listen to your stomach. Listen for absent.
All right, so the first thing you want to check off
How's everybody together is gonna watch?
Take those 12 leads out. What? Do we got more in there?
I'll make sure we get, I'll make sure we make it happen.
Hey, he just said go to lunch.
Yes.
No.
No, you don't.
You are, I know you're already eating.
You don't get to go
Shut
to
up,
lunch.
Dixon. And shut up, Itson.
You're
Yeah,
good,
your
Joe.
protein,
Sign
bro.
off.
I'm always eating.
Yes, you are.
I know.
We know that.
Why I said this.
Let me see your face, John.
Hey, Jones, you're good. You can sign off.
Sign off, Jones.
Log out, John.
Good work today.
Bye, Jones.
Oh, so can't pick this thing first, then.
Yeah.
Back to that line. But I think.
All right, I got you. I'll get the checklist together.
Right? Am I wrong, though?
Then we have a board on them.
And then you'll.
Did he really?
Yeah, this year. Yeah, look. Next to your elbow. Yep.
No, it's not.
Hey, Mark. Okay. We got it in there. This one. This is one of the.
Clearly. Actually, this
Where your section is. So that as you're like bagging, some of the air is going to the purpose of the suction. Is to pull that excess air going to the gastric and just suck it. So it's really sucking air. Let's do the Igel. That's the one we're gonna get tested on. So they did.
Sending Igels down the road, man, that's all. Same thing I do at work, out of work, doesn't matter. You know what I mean? Lubing the tip, turn that motherfucker right in, that's it, man. Yeah. It's pretty lubricated. It's ready to rock. Nothing to it.
I don't need it.
No. When I get deep in that motherfucker, I start ventilating.
All right. Brad, you want to do this Igel thing? All right. All right, so the first thing you gotta do is select and check on assembly. Now, there's two more things that we're doing that we didn't do last time. So, we're going to need Okay, now I'm going to give you the scenario. You're on scene with a guy who's breathing at 3 per minute, shallow respirations. Like this. Take it from us. Yeah, so here's how it goes. And then you actually put on the pulse. So go back. Oh wait, no. Then you'll put on. Then you'll say, okay, I'm going to put in your super block. Put it down and start back. And then next and don't pass it back. We'll switch and then we'll listen for long signs. And then you'll listen to the epigastric. Yep. And then after that, if you need to adjust it, make adjustments. And then make sure you got your end title on and ventilate every 6 seconds. And that's it. So bag. Okay, good. Don't forget that. That's part of it.
Oh, yeah. All right. Try it.
All right, good job, man. I'm gonna go ahead. You want me to attach anything at this point while you're bagging? Okay, and at this point, I want you to go ahead and do your super glide.
Sorry about that. How do you know to pick up? Sir. Go ahead. Sorry, man. 1,300. 1,300.
Good job.
Hey, thanks, man. You see me nail that?
Just grab him. Just grab him.
I mean, it's like you say, it's like, no matter what.
This is a little bit rough.
It's like way on media now, except for Red. It's been like 15 minutes. Dead ass. Dead ass, bro.
Once you got it in the proper bed, you're gonna want to secure it. Did they secure? Yeah, they secured it. Cardiac arrest. They put it in two.
Oh, they did.
Okay. So now we're in there. Now let's start bagging. Yeah, it's that deep, man. I'll tell you. Okay, what else do you want to attach to we go hook it up to your Igel. Yep, hook it up. It goes here. Just like that. Oh, sorry. Just like that. And then your bag, elbow. So we got Untitled, we got pulse ox being read, and let's see if you got it. We get some good chest. Okay, so now we're bagging. We got all our stuff together. What do we do to verify that air is going in the lungs and not the epigastric?
Yeah.
All right, so I'll do that. Well, in the check sheet, you got to do it. So you'll just pretend. All right, so I'll pretend somebody else.
you doing? Switch nigga sound?
Yeah, it'll push down a little harder.
Gotta push it down. Things left to right, left to right.
Okay, and after that, ventilating, what rate are you gonna ventilate, Mops?
Every 6 seconds.
Okay, that's it, man. We'll run it back. All right. Not bad, man. Just bag them. Make sure you do your pulse ox during the bag stage, and then super glide.
Yes, sir. The phone with.
The jam.
Oh, no.
Yeah. the goodness
That's
there.
what we'll be calling it. You just gotta remember all this equipment.
You guys want to go to the lunch table outside?
I know it sucks.
Okay.